So as you know, we've broken up the neurologic pharmacology a little bit, so let's talk about headaches. So as always, I like to start with a case. Katie's 20 years old. She's a nursing student. She's having a headache. What do you need to know? Lots of different kinds of headaches, lots of different pharmacologic approaches. So usually we break headaches up into a few major categories. Muscle contraction headaches, previously known as tension headaches. Migraine headaches and cluster headaches are three of the more common ones. Obviously, there's others as well. So, how does the pathophysiology relate to the pharmacology? Well, headaches are usually caused by nerve, muscular, or vascular changes. And when she gets a headache, either her nerves, her muscles, or her vessels are affected. And so, pharmacologically, we're going to try to address the appropriate issues. So, muscle-based headaches, just as they say, are predominantly related to pulling on the muscles of the neck, usually related to tension, and so they have pain, then they become more tense, then they get more pain, then they become more tense. To treat these, we could use something that relaxes the muscles. And so many people will use something like cyclobenzaprine, also known as Flexeril. There's other muscle relaxants as well. Soma is one that you're best probably to stay away from just because it has some psychoactive effects that you probably just don't want to get into. But Robaxin, some people even use baclofen, but there's a number of different muscle relaxants. There's also medicines that we can use that will affect both muscles and vascular. Fioricet's an example of that. We used to think of it as a migraine medicine. Now we use it predominantly for muscle contraction headaches. But the caffeine that's in it is going to cause some vasoconstriction and have some effect. We used to break headaches down to either muscle contraction or migraine. Now that we know that they kind of exist on a continuum, and lots of times they're going to have elements of both. Migraine is a medication that used to be around. It's really hard to find now. Basically, it is the same kind of thing as Fioricet. In Fioricet, the phenobarb is the sedative, pretty low dose of phenobarb. But as you remember, phenobarb is a GABA-type medicine that will sort of make someone a little bit more relaxed and a little bit more happy. So in a nerve-based headache, what causes the nerves to be irritated? There's some kind of inflammation. In something like temporal arteritis, you actually usually have inflammation of the temporal artery, although there's also various other vascular elements that can be inflamed, and in those we refer to them as giant cell arteritis, but basically the two can be considered as roughly equivalent. And in those cases, you get those inflammatory processes, almost like a rheumatoid process, and you get a substantial headache. With temporal arteritis, you'll sometimes also get a little bit of transient monocular blindness, which, as you know, is also referred to as amaurosis fugax. And if you have that, obviously it's a bit more concerning. You need to do a differential process, to really completely rule out temporal arteritis. You're going to need to do a temporal artery biopsy, but it's really seen in older people. 95% of the people are going to have a SED rate above 40, so you'll definitely use these as part of your differential process. You can, as noted, have other headaches that are less common, meningitis type headaches. Meningitis is caused by usually either a virus or a bacteria. The viral, not dangerous, not terribly likely to cause major issues, but they hurt like a son of a gun, and sometimes those people even need to be admitted to the hospital for pain control. Trauma can also cause headaches, post-traumatic concussion type headaches, but those are addressed elsewhere. So other vascular headaches. Well, usually when we think of vascular headaches, we think of migraines. And migraines, one of the more common theories is that they basically have alternating areas of dilatation and constriction in the blood vessels. So if we dilate it all or we constrict it all, it's usually going to cause less headache. These people also have been known to have lower levels of serotonin, especially certain types of serotonin, and this is why the abortive medicines that we use for these headaches are a type of serotonin. And so we also can use other medicines, especially for prevention, that dilate or constrict the blood vessels longer term. So to constrict, we'll use a caffeine-like drug or caffeine itself. And basically, it looks like the neurotransmitter that causes vasoconstriction. And to dilate, you can use a sympathetic nerve blocker. Beta blockers or calcium blockers. These are usually used as a prevention, a long-term therapy, but there are some newer therapies that are looking at doing this shorter term. Serotonin, and again, especially short term, we can give a medicine that stimulates those serotonin receptors. Most likely the triptans, those stimulate the 1B and 1D receptors, and also maybe some other receptors as well. And so they will sort of normalize those dilated arteries. They'll inhibit peripheral nerve conduction. And they also do inhibit transmission through that trigeminocervical complex. The most common triptan that we'll see is sumatriptan, or at least it's the oldest and has the greatest time. It does have a somewhat shorter half-life. You may need higher doses. Some patients get chest tightness, and if you give the injectable Imitrex, you'll want to give the first dose in the office just to see, just because those people are much more likely to get chest tightness. But there is a nasal version. There's other triptans that do have sublingual versions. And you do need to remember that since triptans are serotonin drugs, if you give them to people on SSRIs, there is a real risk of serotonin syndrome. Tramadol is also a serotonin type drug, so if you really want the trifecta, you give them all three, and then usually what happens if you get enough stimulation is serotonin syndrome. If it's going to happen, it'll usually come on fairly rapidly. A mild case will give you a little bit of a tachycardia. They might shiver a little bit. They might sweat a little bit. They'll have a little bit dilated pupils. They may have some twitching. As you know, lots of other things can cause this as well, and in some cases these people are thinking that they're having a panic attack because of that increased heart rate and those other feelings. A moderate case of serotonin syndrome is going to have hyperactive bowel sounds, blood pressure is going to go up, they may have a bit of a temperature. In extreme cases, it can go up as high as 104 Fahrenheit. They'll have increased reflexes. They may have clonus, which is when you check reflexes and you have a sustained response. They may have more of a response in their lower limbs than their upper limbs, and they may have mental status changes like hypervigilance and agitation. Severe symptoms, obviously, they can go to a temp of 106. Heart rate and blood pressure can actually go up and then go so fast that the person actually goes into shock because the blood pressure will usually actually start to crash. They can have metabolic acidosis, rhabdo, seizures, renal failure, and other issues. So natural therapies sometimes are used for migraines. Feverfew seems to have some benefit. It's basically the equivalent of an NSAID. Little editorial comment in here. I don't think something's better just because it's natural. Tobacco, strychnine, and arsenic are natural too, although there's many patients that really do like to use natural medicines. The problem is that natural medicines are not regulated by the FDA, so they may have just exactly the same side effects, but they're not listed anywhere because nobody's required them to. Side effects from Feverfew can be upset stomach, heartburn, diarrhea, constipation, bloating, flatulence, nausea, vomiting, nervousness, dizziness, headache, trouble sleeping, joint stiffness, tiredness, menstrual changes, rash, pounding heart, and weight gain. Patients on Feverfew will almost never have heard that these can happen just because they think they're natural and they don't get side effects. Safety for Feverfew beyond 4 months use has not been studied. Some people chew it instead of swallowing it in a pill. It can cause mouth sores, can cause swelling, and we do think that Feverfew is possibly unsafe, may cause miscarriage, and as we know, NSAIDs late in pregnancy can also cause closure of that ductus arteriosus, and we also don't know if it's safe in breastfeeding. People that are allergic to ragweed are often allergic to Feverfew as well. And so the other members of that family are chrysanthemums, marigolds, daisies, and a bunch of others. And so if you've got those kinds of allergies, make sure that you talk with people. I'm sorry, if your patients have those kinds of allergies, warn them that they may not tolerate Feverfew. It also can slow blood clotting, so if you have somebody that's either going to have surgery or is on blood clotting medication, they should take that into consideration. Extracts of Feverfew actually inhibit platelet serotonin, and so you may actually have other unexpected side effects. So you also could be a little bit more likely to get serotonin syndrome with these medicines. Another medication approach to migraines that I use a lot is what I call RiboMag, which is 400 milligrams of riboflavin, vitamin B2. It doesn't usually come in this dosing in the grocery store or even basic pharmacies. Sometimes you have to go to GNC. But the magnesium should be in a form that is easily absorbed. Now, mag oxide and a bunch of the other magnesiums do not absorb well, and that's what makes them such good laxatives, is that they basically go through the intestine without absorbing, and they draw fluid into the intestines osmotically. Magnesium glycinate or gluconate really do seem to be among the best absorbed. They often come in a 500 milligram tablet. Other prophylaxis, as we mentioned earlier, you can use beta blockers, you can use calcium blockers. Tricyclic antidepressants also can be used for prevention of migraines. There's a number of different anti-seizure medicines. I've had the best luck with Topamax over the years, but there is a number of different medicines, and I would encourage you to familiarize yourself with those. Cluster headaches usually are unilateral. They often do have tearing or a runny nose on that side. You can use high flow oxygen if it's available. If it's not, you can go ahead and use a Triptan type medicine and treat it as if it's a migraine type issue. So again, anytime you're giving somebody one of these kinds of medicines, consider the serotonin impact, consider interactions. Sometimes birth control can actually make headaches better. Sometimes birth control can make it worse. And so, as with all medicines, make sure you understand the side effects, adverse reactions, dosing, route, just because many of these medicines can be done sublingually or injectably. And a number of the triptans actually come in a nasal form. All of them are actually pretty pricey. But if a patient really has a lot of migraines, they're more than happy to pay for it usually. We do encourage them to use the triptans early, but because they're so expensive, there's sort of a mixed feeling about that. So you'll see lots of patients with headaches over the years, something that's worth some time figuring out.